My topic for today is anesthesia concerns for TURP surgery. It is a very commonly done surgery, transurethral resection of prostate, and it is the surgery of choice for BPH, benign prostatic hypertension. Now, BPH, this is enlargement of the prostate. It leads to bladder outlet obstruction syndromes. So, generally, the normal size of prostate gland is 25 grams. When it is enlarged around 60 to 80 grams, then this is the surgery of choice, TURP. And for very large prostates, the surgery of choice becomes open or robotic prostatectomy. Now, for TURP, this procedure is performed in lithotomy position using a resectoscope through which a diathermy loop is passed. Now, what are the concerns for this surgery? Patient population, it is generally elderly patients and they have a reduced organ reserve, multiple interacting comorbidities are present. Then, because of their general physiology, there is limited ability to compensate for hypotension, volume overload, electrolyte shifts. And here the outcome depends more on the comorbidity optimization than the anesthetic technique. So coming to the preoperative considerations, it is predominantly performed in the elderly males. Clinically, the patient presents in the age group of 60 to 70 years predominantly. So there is a high prevalence of cardiovascular disease, CKD, cognitive dysfunction, polypharmacy because the patient will be on multiple comorbidities. Then there is, as I said, reduced physiological reserve. So there is narrow margin for anesthetic error. And this is a table summarizing all of those risks. The patient will have poor tolerance to volume shifts and in renal compromise will be there. So the patient will be more prone to cognitive dysfunction. Autonomic responses are already blunted, and then if the patient has diabetes, then there will be chance for exaggerated hypotension. So these are the things we need to consider before the labs and everything that we do. This is more important that you check the patient's functional status, MEDS, frailty indices, cardiovascular evaluation, if the patient has coronary artery disease or heart failure with preserved ejection fraction, arrhythmias, pacemaker in situ, renal function, the patient may have higher chances of renal dysfunction. So it is necessary to have a baseline creatinine and electrolyte levels. Again, this post-op cognitive dysfunction is more common. So there is a more risk of dementia, delirium. So it is important to have a cognitive baseline in a pre-op patient. The patient may have multiple medications, anticoagulants, alpha blockers, diuretics, antihypertensives, OHAs. So those are all the things that we need to evaluate in the PAC. Coming to each system, the concerns in the cardiovascular system, the patient will have stiff ventricles, there will be a present diastolic dysfunction. On top of that, spinal anesthesia, which we generally give for TURP patients, it will lead to a decreased SVR and a decreased preload. In TURP fluid absorption, the patient will have sudden volume overload and the ventricles are not capable of adjusting to this. So again, why TURP stresses the heart? Sudden decrease in SVR, acute volume absorption of the irrigation fluid, hyponatremia leads to myocardial depression and autonomic instability. Going for the echo numbers, it may not be as equivalent to looking at the functional capacity. Is the patient able to climb 2-3 flights of stairs? What is his usual daily activity? Then if the patient has a diastolic dysfunction, this we look at the echo and mostly we disregard this. But if the patient has diastolic dysfunction, these things have to be taken into consideration to avoid tachycardia and to avoid fluid overload. And in cases of severe AS, this is a specific case where TURP is done only if it is unavoidable. And even then, GA is more preferred. And then the medications that have to be continued, beta blocker statins. Looking at the thrombotic risk of the patient. So in the patients of TURP who are already on receiving anticoagulants, there is a high bleeding risk. Spinal anesthesia, again, there is a risk for regional anesthesia, neuraxial anesthesia. So in cases of patients receiving anti-thrombosis versus bleeding, then you have to check all of the medications the patient is on and follow ASRA guidelines for stopping or continuing them. It is better to have a multidisciplinary approach, coordinate with urologist and cardiologist. And at last, if the neuraxial is unsafe, you always have the option of GA. TURP specific risk, the patient has a lot of irrigated fluids are coming, so there is inability to excrete those. There is dilutional hyponatremia, post-op AKI from hypotension or volume overload. So things we have to take care of, establish a baseline creatinine and sodium. Correct pre-op hyponatremia. These old age patients, they are prone to have hyponatremia pre-existingly. Avoid aggressive preloading. For spinal patients, we have to do a careful preloading in these patients. Prefer isotonic irrigation. Prefer a bipolar TURP. Avoid nephrotoxic drugs. Diabetes, the problems in elderly patients having diabetes, the autonomic neuropathy, it can lead to autonomic regulation system of the patient can go into disbalance. There is a silent ischemia may be present. CKD is coexistent. Coming to TURP specific concerns, There may be stress hyperglycemia, delayed wound healing, increased infection risk. So for management, we tend to avoid both hypo and hyperglycemia. We hold OHs appropriately, and it is good to have a monitoring intra-op, post-op, and prevent hypoglycemia. CNS, again a syndrome, again a system which we don't pay much attention to. The patient may have a history of prior stroke or TIA, carotid atherosclerosis. In TURP, hypotension can lead to cerebral hypoperfusion. Hyponatremia, it can lead to cerebral edema. All of this, it can increase the post-op delirium risk. So it is always good to have a pre-op cognitive baseline, avoid benzodiazepines or sedatives, and correct the hypoxia, electrolyte imbalance, hypoglycemia, and adequate pain control pre-op and post-operative. So coming to overall management, drug interactions also need to be looked at. Alpha blockers, they can cause exaggerated hypotension. If the patient is already on diuretics, it can cause electrolyte imbalance. Again, it is good to avoid sedatives. They may cause delirium. And elderly patients already have a weakened system, altered pharmacodynamics. So it is good to prefer a low dose spinal anesthesia, have a tight hemodynamic control. Fluid therapy, again, aggressive preloading is not really required. And again, as I said, multidisciplinary approach, all the cardiologists, urologists can have a communication beforehand. These are all the regular pre-op evaluations, and again, all the other things that I mentioned before, the other symptoms, they also need to be taken into consideration. Coming to choice of anesthesia, regional anesthesia is the preferred technique of choice for TURP. Level of sensory block, T10 is preferred. Since it covers all of your levels, it eliminates discomfort caused by bladder distension. The sympathetic nerve supplies T11 to L2 and inferior hypoglossal plexus, and parasympathetic nerve supply to prostate is S2 to S4 and pelvic splanchnic nerve. So if you achieve a T10 dermatome level, all of these will be covered. Since I keep saying that regional anesthesia is choice, so this is a comparison in both of those. The hemodynamics will be better with GA, but TURP syndrome, which is a very common complication, it is earlier recognized in the regional anesthesia. Renal safety, delirium risk, it is again lower in spinal anesthesia. Hence, for all of these advantages, spinal anesthesia is or regional anesthesia is preferred over general anesthesia. GA is considered when it is a contraindication to spinal anesthesia. The routine monitoring that we do here, the things that are increased, one thing we have to look more carefully is the mentation of the patient. It is good to keep talking with the patient and look for any derangement in CNS or look any delirium or any electrolyte imbalance symptoms. These were all the pre-operative. Now coming to intraoperative considerations. Why is this surgery different? Because of lithotomy position, TURP syndrome, bladder perforation, hypothermia, hemorrhage, coagulopathy, all of these may happen intraoperatively. Lithotomy position. Already there will be a decreased FRC, increased venous return in the lithotomy position. In case of a spinal anesthesia, the lithotomy tends to exaggerate the hypotension or increase the level, and there is a decreased venous return following the lower of legs after the in post-operative period when we return to supine position. And other complications, nerve injury, finger injury, compression of major blood vessels, lower extremity compartment syndrome. And the next three, they are more because of the geriatric patients. They may have osteoporosis, limited joint mobility, and pressure sores. Coming to TURP syndrome, this is the most common thing that we have to focus during the TURP surgery. Why elderly patients are at the higher risk? Because there is a reduced renal free water clearance. All the irrigation fluid, it is not getting cleared as rapidly as a young patient. Impaired cardiac compensation and baseline hyponatremia is common in the geriatric patients. The common irrigation fluids that we use, NSRL, glycine 1.5%, mannitol 3%, sorbitol 3.5%. The qualities of an ideal irrigation fluid is transparent, electrically non-conductive, isotonic, non-toxic. Such an ideal irrigation fluid doesn't exist such as of now. Coming to electrolyte-free hypotonic solutions, they are good for because they are hypotonic, but then they can cause fluid overload, dilutional hyponatremia, etc. This is an overall view of the pathophysiology of TURP syndrome. The risk factors are open prostatic sinuses, high irrigation pressure, lengthy resection, hypotonic irrigation. All of these, they lead to irrigation fluid absorption. This leads to increased volume, hypervolemia, which goes on to hypertension, bradycardia. Since the patient may already be in spinal, it will be exaggerated by these things. The patient can, because of hypervolemia, go into left ventricular failure, causing in severe cases pulmonary edema. This is again exaggerated by the hypoosmolality caused by hypernatremia. Cerebral edema, because of the hypervolemia, it can lead to visual changes, encephalopathy. In severe cardiovascular collapse, it may even lead to death is reported in 1% cases of TURP syndrome. Factors affecting irrigation fluid absorption. The larger the size of the gland, It is 25 ml per gram fluid is absorbed. Number and size of open sinuses, hydrostatic pressure of the irrigating fluid, duration of the procedure, integrity of capsule. If the capsule is broken, it is more fluid is absorbed. Venous pressure at irrigant blood interface, and vascularity of diseased prostate. This is a table showing you clinical features of TURP syndrome. Presentation begins from 15 minutes to 24 hours after the operation, and you can have such a variety of symptoms. Patient may have neurologic symptoms, nausea, visual disturbances, seizures because of electrolyte disturbances. Cardiovascular patient may have hypertension, reflex bradycardia, pulmonary edema, severe collapse. In hematologic patient may have renal failure, metabolic acidosis because of glycine. Any of these, they show up, it is good to check for a TURP syndrome or have that diagnosis in your mind. Hyponatremia, because of lot of dilutional fluid. Hyponatremia is because of dilution. Water intoxication, it may cause cerebral edema, which manifests as somnolence, restlessness, seizure, coma. And the signs of hyponatremia at various serum levels, they are shown in this figure. At severe levels, you may have seizures, coma, even death. Management of TURP syndrome, it is largely supportive, conservative management. The important thing is early recognition of the syndrome. Supplemental oxygen is provided in cases of pulmonary edema. Affected patients should be warmed if hypothermic, may require antiemetics for nausea, vomiting. Serum sodium should be corrected slowly and monitored closely. Now, for serum sodium levels less than 120 milliequivalents per liter, only for those cases, 3% NS or hypertonic NS is given. As soon as serum sodium level reaches 120 milliequivalents per liter, it is good to do a very slow correction. There is no need for aggressive serum sodium correction after 120 milliequivalents per liter. Diuresis, it is useful only in the early symptoms. Otherwise, in severe cases, concurrent diuresis might have an impact on rate of sodium correction. Again, a 4 to 6 millimoles per liter increase in serum sodium concentration is adequate in most seriously ill patients. Hypertonic saline only indicated when sodium is less than 120 millimoles per liter. Diuretics are usually used either in the very early periods or when acute pulmonary edema is prominent. More than management, the important thing is prevention of TURP syndrome. Minimizing negative outcomes relies on limiting the absorption rate of irrigation fluid, recognizing complications early, and providing prompt resuscitation. So, general principles use adequate fluid status, adequate venous pressure, reducing operative duration less than 1 hour, delivering irrigation fluid at the lowest required pressure, warming wherever possible. In patients of spinal anesthesia, hypothermia is a concern, and giving cold irrigation fluid is again will increase the hypothermia. Using warm irrigation fluid does not increase blood loss by regional vasodilatation, but monitoring of perioperative fluid balance is important. And vigilance for early signs of mass effect and fluid overload. They should, so again, it is more important to prevent this TURP syndrome. As we already discussed, regional anesthesia, technique of choice for TURP surgeries. The reduced risk of bleeding and use of saline as irrigation fluid make this a favorable technique. Coming to the type of surgery, monopolar versus bipolar, it is shown that bipolar TURP has some advantages, including reduced incidence of TURP syndrome because there is a less use of hypotonic irrigation solutions. Most important things to be looked at vitals and the mental status of the patient. Information on patient's vital signs, input output of irrigation fluid, blood loss, and electrolyte monitoring. That is a basic thing to do during TURP surgeries. Another complication, bladder perforation. Incidence is 1%. It can be caused either by trauma by a surgical instrument or over distension of bladder by irrigation fluid. Intraperitoneal may require a surgical repair. Extraperitoneal bladder repair is generally conservative. The manifestation, it will appear as lower abdominal pain or distension, unexplained hypotension, reduced urine output, hematuria out of proportion. There will be a discrepancy between the irrigation fluid that is going in and coming out. And the features of TURP syndrome may coexist. Then there is rising airway pressures under GA, and delayed abdominal distension in a recovery may also point to bladder perforation. The concern for blood loss, it is difficult to quantify blood loss because visual estimation may be difficult due to dilution with the irrigation fluid. And again, the patient is under spinal anesthesia usually, so the warning signs of tachycardia, hypotension, they can either be masked by overhydration or effects of spinal anesthesia. So there is the estimation of blood loss can be done by resection time. More the time, more the blood loss is expected, size of prostate, and number of open venous sinuses. Hypothermia, again, continuous fluid irrigation causes loss of temperature at 1 degree Celsius per liter. Elderly patients, they already have a reduced thermoregulatory response, and unintentional hypothermia is associated with a significantly higher incidence of postoperative MI. So the measures to maintain normothermia, warm blankets, warming IV fluids, and administration of heated irrigation solution. Summarizing the post-op complications that can happen: hypothermia, hypotension, hemorrhage, septicemia. The patients may already have a UTI, and septicemia on top of that can happen. TURP syndrome, bladder spasm, clot retention, and post-operative cognitive impairment. These are all the complications that can happen. Delayed TURP syndrome, as I said, from 15 minutes to 24 hours post-operatively it can happen. So it can appear as confusion, hyponatremia. Glycine toxicity can lead to visual disturbances if glycine is used as irrigation fluid. Clot retention, urosepsis. Delirium. In cases of delirium, it may be because of post-op cognitive impairment, but it can also be a sign of urosepsis. Thank you.